On today's episode of Back and Brew, I'm so excited to have Dr. Jack Rentz. He's an interventional pain physician who specializes in acute trauma care. He is also an innovator in the space of stem cell, PRP, and regenerative medicine. This is Back and Brew. So, Dr. Jack Rentz, thanks for coming on. It is Back and Brew, so let's start out with the brew. You picked something that's near and dear to my heart, a Louisiana beer, Abita. Tell me a little bit about it.
So I was introduced to Abita when I was at my fellowship training in New Orleans. Abita is on the North Shore of Lake Pontchartrain. Abita is a spring town, and they brew great beer there.
Yeah, absolutely. It's funny. I think we were talking about this before the filming. I don't think I've ever had an Abita bottle without having a Crystal Hot Sauce bottle right next to it.
I don't think I have either. So it's either Crystal Hot Sauce or shrimp and crawfish.
Oh, it's fantastic. So, without further ado, it's a great way to start a Friday. Hey, cheers, man.
Cheers.
Yeah, this is it's interesting because you would never think of Louisiana as the place for a good beer.
Good beer.
Yeah.
I mean, the South in general, because I think there's a water issue. So typically, it's got to be spring fed, good quality water is the only way to really get good brew.
Yeah, I mean, the funny thing though, but that's also what makes like their bread so good, right? Is like the bread that you get for po' boys is because it's from whatever the hard water is that they have in New Orleans and in the South in general is apparently makes a better bread. But yeah, I absolutely love this amber lager, super approachable. I think it's a better version of Fat Tire.
I would agree.
It's funny. Again, from spending so much time in New Orleans as a kid, and then even as an adult, committing to spending multiple trips there, I knew Abita well. And then when I went and tried Fat Tire, I don't like Fat Tire, and I think Abita Amber is one of my favorites.
Doing residency in New Orleans, it was one of the staples. You have everybody has it everywhere. It's on tap everywhere. It's it's just an easy drinking beer.
Absolutely. What's your favorite restaurant in New Orleans?
My favorite restaurant I've been to recently was probably Stella, but also Commander's Palace is always a staple. You got to go there if you're ever back in town.
Yeah, that's a classic. That's everywhere. We make like the same stops unashamedly.
Yeah.
Giacomo's
is great. The hot dog place.
Yes.
It's amazing if you ever get a chance. Yeah.
There's this like Jamaican restaurant. I think it's called it's like Seven Seasons or Seven something over by the World War II Museum.
Okay. Yeah.
Have you been to that World War II museum?
I have. It's an amazing thing.
Amazing. One of my favorite museums of all time.
I've been to the D-Day Museum actually at D-Day in France, and our World War II museum is incredible.
The New Orleans World War II Museum, I think, is like a 2-day experience. Yeah. Like the first time we went, we had about 45 minutes before closing, and I was like, "Oh, we'll just go through it."
Yeah.
We got to
come
the
back.
entrance. Yeah, and it is by far, I think the best way to leave the U.S. without leaving the U.S. is going to New Orleans.
Oh, it's a European city that happens to be in the U.S. So
absolutely. So tell me about your training there. That had to have been a wild place to do residency.
It was post Katrina, like the year post Katrina, and so there was really only Ochsner Clinic is where I did my anesthesia residency at, and then we did have some satellites that were open. So the original charity hospital was actually shut down due to health issues there. They did open up a satellite, basically freestanding emergency room with some beds, and we did our trauma training at the charity kind of temporary hospital, which was pretty wild post Katrina. A lot of trauma, a lot of stuff going on, but it was absolutely incredible training, incredible people, very gracious, fun, amazing. The hospitality while we were there was just super impressive.
It's interesting. So when I was a kid in New Orleans, I was there because my aunt and uncle were doing. My uncle was doing his residency there, and my aunt was going to med school there. And so I just go down there for part of the summer, hang out with them, and like just be in a different place, right? And I remember walking through the quarter with my uncle, who's an orthopedic surgeon. He was, and a homeless guy every single time would be like, "Dr. Knock, how you doing?" Like he's like, "You staying off that leg?" Yeah, yes, sir. Yes, I am, doc. Like, just like the friendliest people.
Oh yeah,
I have ever met. hands down. Also, some of the roughest areas I've ever seen.
Well, there's definitely rough areas all the way through there, and places you don't want to be, during nighttime. But honestly, most of the place is pretty safe.
I would argue it's gotten safer since Katrina too, right?
It's gotten better, probably way safer since Katrina.
I heard this one statistic that pre-Katrina there were 700 restaurants. Post-Katrina, there were almost 1,400 restaurants.
Oh wow! Yeah.
That were in like proper right in the parish, and so I was like, oh, that's interesting. Like that's inevitably it got somewhat safer there. So you went through your residency there. Now, is what's really interesting about you is that you are not only an amazing, talented doctor, but you're really good at business and you understand the economics and how to utilize that to really offer patients more and better care than they would be able to go to if they go to most other pain docs, at least in my experience, where, the first time they're like, well, insurance, they might say no to that. You have dialed it into where you can really customize patients' plans to the latest and greatest technologies that there are. Whatever got you thinking about doing something beyond just med management?
I mean, really just being restricted of what insurances dictate what you can and can't do. Limitations on not being able to treat somebody's neck and their back at the same time. Just trying to think outside of the box kind of lets you explore what avenues. And when you let go of, I have to do it a certain way, I mean, the world's your oyster. Typically, learning cash business, learning regenerative medicine or orthobiologics, stem cell, PRP, learning, wellness, whether it be advanced, optimization, hormone replacement, all plays a role in recovery, whether it be acute pain or chronic pain. And then also just not learning that you have to do it one way each and every way. And there's patients out there that don't have insurance. How do you treat those patients better? And just being open in your practice to being fluid with what you can and can't do is really kind of benefited my practice.
It's really cool to see that perspective taken, especially I was a spinal cord stimulator rep in Tennessee and covered some rural Tennessee areas. And there were some practices that were just built out of there, just pills. That was it, just pill mills, right? There were a couple great doctors out there, don't get me wrong, but there was a lot of them that were the highly profitable ones were the pill mills.
Yeah.
And it's interesting to see that you evolved past that with a conscientious effort and understanding of opioids. How do opioids factor into your treatment plans?
Opioids is really only clinical indication for short bursts of opioid treatment, whether it be recovery from surgery for up to 3 or 4 months, or to deal with acute pain for short periods of time. There's really no great data that says opioid treatment long term really benefits patients, their health or their happiness. Long term, opiates have tremendous side effects. They suppress natural hormone release. They cause depression in almost every patient. Besides the side effects of dry mouth and oral health being an issue and GI health being a big issue with constipation, really they don't really help people long term. Now, one area where they do is in terminal illness. There's great data that proves that there is a place for long term opiate use, but other than that, it's really hard to justify continual med management.
It's funny too, because like right away, I remember whenever I've gotten any kind of small procedure done, there's always immediately well, do you want us to write you something? Do you see that? Do you see that a lot in the community in general?
I mean, typically most people are just afraid of being in pain and they have anxiety around having pain. And so a lot of people are asking for prescriptions and it's kind of guaranteed like, hey, I'm going to get something just in case. And some of that's just, our kind of perspective of I want it now and not being able to really understand and, grin and bear it for a little bit. I mean, obviously some things do require opiate management short term just to make sure you're functioning. But I think it's really, we were all graded with the JACO, which is a, federal agency back in the day that kind of started this opioid crisis because we were undertreating pain per patient perspective in the hospitals. And that's what kind of stimulated this big opiate rush. Is because we were underutilizing pain management.
Do you think it was truly underutilized? Do you think pain management was true, or do you think the patient's pain was being inadequately treated, or do you think that the development of opioids and the business around it was just being built faster?
I think a little bit of both. I mean, I think you push patients one way, and obviously, when you're in the hospital, you're going to be uncomfortable. So that's a guarantee. I think there. I mean, as we see now, big pharma is a huge industry. They have way more power than we could ever imagine, and I think looking at these big pharma companies very critically, especially when it comes to addictive drugs, I think hopefully, we take a good hard look at maybe some changes.
What are some ways that you treat pain that you've seen to be really effective but not involve opioids?
I mean, injection therapy is really, kind of my mainstay, and that could be traditional steroids, ablation procedures where we burn the nerve. It could be orthobiologics, so PRP, stem cell harvested from their own, bone marrow, have really taken off. Even today, we're doing more of the orthobiologics today than we ever have, and we're doing less and less steroids because we're finding that steroids, either into the epidural space or into joints, definitely have consequences, as where some of your natural PRP substances do way better long term compared to steroids, and also have less side effects.
Interesting. What is so kind of break down the stem cell PRP.
Yeah.
One, the difference between what is the difference between stem cell and PRP?
So PRP is platelet-rich plasma. So it's essentially we basically draw whole blood from a person, put it down in a centrifuge, and the centrifuge isolate layers based upon gravity. And so we're able to take out the red blood cells, and what's left is platelet-rich plasma. So it's a concentration of white blood cells, platelets, and growth factors and other intravascular milieu that we concentrate and we inject into an area to stimulate someone's immune system to more robustly heal that area.
Interesting. Okay. Um, do you use is stem cell and PRP therapy used in the treatment of car accident injuries?
Yeah. So in my practice, we do a lot of orthobiologics for car accidents because a lot of the acute pain population, which a car accident victim is, they perform and do very well with PRP and with stem cells. So we're providing those patient populations those type of injections, whether it be cervical neck facet injections or lumbar epidurals or intradiscal therapy.
Will the so like let's say that you have someone that comes in after they've been rear-ended in a car accident, right? And you designate, you say, I think a good way that a good treatment plan can start that we can start with for your neck injury, for example, is let's try some PRP. Will the other person's insurance who rear-ended them, or the company, or if it's a company car that rear-ended them, that company's insurance, will they pay for the PRP treatment?
Yeah, so they'll pay for the PRP treatment. Right now, regular health insurance, the big payers aren't covering PRP, but Colorado Workman's Comp actually covers PRP injections in the shoulders and knees. So a lot of the insurers are starting to cover it more. For car accident victims, if another person has a liability, they are paying for these new treatments because there is great data, peer-reviewed journal data out there on using PRP and stem cell to treat discogenic herniations, facetogenic whiplash injuries to the cervical and lumbar spine, as well as the shoulders and knees.
Oh wow, that's an interesting thing. Is like I feel like most of these patients that are in car accidents, or even the workers' comp patients, are they usually surprised to find out that stem cell and PRP could be covered by whatever their plan is or whatever the case is that's going to be taken out?
Typically, they are. I mean, most people hear PRP and or stem cell, and it's associated with some elite athlete getting some recovery training from an injury to get back on the field a little bit sooner. But I've been doing regenerative medicine for almost a decade, and most of it's been cash based. But now we're doing more and more on personal injury cases and work comp cases.
Why doesn't insurance pay for stem cell or PRP?
It's a great question. I think they would say that there's limited data, and it is still a new and emerging field, and we're changing our algorithms and refining our craft. But every day, all day, I'm recommending more and more regenerative options than steroid options. Even when I had a rotator cuff tear myself, I had my staff perform a PRP injection for me versus a steroid injection.
Dude, Sean Dugan swears by your algorithm for
Yeah.
his shoulder. He was like, man, he's like, I was at the point where I thought I was going to have surgery on my shoulder. And it was funny because I asked him, I'm like, dude, do you believe in stem cell and PRP? Just out of curiosity. And he's like, yeah, I get that therapy done. And
you know, you kind of have to be converted, have to be a believer. But once you get converted, it's, you know, there's really low risk. You know, all this started with horse racing. I don't know if you knew that. Yeah. So,
wait, you're telling me the stem cell therapy and PRP started with horse racing?
It did. So at least PRP did. So when horses are training for the Triple Crown, they overtrain them. And obviously, people know the weakest part on the horse is their ankles. You know, if it goes down, you've got to put them down if they have a big injury. So they're constantly monitoring these ankles, and they were coming up with ways to basically get more robust healing or quicker healing. And they started to inject prolotherapy, which is basically hypertonic saline or steroid glucose into the ligaments and joints. And what they were doing was causing a chemical irritation to stimulate growth to kind of promote healing. And that did pretty well with them, but it wasn't quite enough to really get the horses where they needed to be during this overtraining cycle. So they started to pull out whole blood from the horse and injecting whole blood, mimicking trauma into the ankle. Two things happened. Number one, some horses recovered very, very quickly, did amazing. Some horses would swell to the point where they couldn't train. So they said, well, what's super inflammatory in this blood? And they started to put it in a centrifuge and take out the red blood cells. And then they started injecting PRP essentially into the horse. And that was the perfect combination of stimulating their immune system to heal, but not swelling to the point where they couldn't train. So it was this perfect balance. And yes, it was really intelligent veterinarians and these, you know, dealing with these tens of millions of dollars of horses that kind of figure some of this out for us.
Isn't it funny how if money's tied to it, innovation happens?
Money is always tied to innovation.
It's interesting. We work with in a lot of markets, and we have some great connections in some of the international markets. And it's interesting that like from some people in the European market, they'll look at the U.S. healthcare system and they'll be like, "Oh, it's just a disaster." Like, you know, people are paying; they have to pay for their healthcare, yada yada yada. And at the same time, like they'll have if they have like a dislocated shoulder or they have like an AC joint injury, a lot of times they can't get it repaired because it's not critical or it's not, you know, it's not emergent. And it's just interesting to me to see when healthcare and business mix, there is a way that they can benefit each other. But obviously we see it on either sides of the ditch where it benefits neither.
Yeah. I mean, I think my partner, Dr. Matt Lucas, he sees a lot of patients that come down from Canada because their system in Canada is so slow of getting routine care and treatment that a lot of people, that are well off up there decide to, come to the States to get more acute issues done.
Does he run ads or do anything in Canada, or is he from there, or what?
No, he's has been partnered with some physicians that are Canadian that have people come down.
Oh, is that the what's his name? Yeah.
Some of the OCC
guys. Yeah. Okay. All right. I know that. That's interesting. Yeah. Some of them are Canadian too.
Yeah. Some of them are. Yeah. So they have a good connection with that.
That's interesting. I wonder. I've always heard this, and I don't know if it's true or not. That like a lot of the Canadian diplomats or politicians will hop over the border to get their care. I wonder if that's true. Have you ever heard?
It is true, and also, I mean, when insurance denies claims of people getting injections and surgeries, a lot of people decide to pay cash. So it's the same system actually happens here in the United States. When you have a very restrictive, or they don't want to use a certain product, they're denied care, and so patients just convert over to cash pay.
Is it hard to get people to flip that switch of my health care is going to be paid for out of pocket as opposed through insurance?
I think when you really see when you understand that insurance is trying not to pay for your care and you really see the business behind it, I don't think it's a big jump to realize like, hey, it still is on you to be healthy. It still is on you to practice, good practices of health to keep yourself as healthy as possible, because people don't realize like your largest expense as you age is going to be your health. It's not going to be your living expenses. It's not going to be your retirement. It's actually your physical health is going to be your biggest cost as you age. So you should be putting as much into the early retirement health bank as you can. You should invest in your health just as much as you invest in your 401k.
That's interesting. Do you think there's, we have products like HSAs and things like that. Do you think they'll become more prevalent as I think people go down and recognize the route of self-paid healthcare more and more now?
I'm a big fan of the HSA. I do believe, like, honestly, me and my family, we're fortunate to be very healthy, but we still have some issues. But we use HSA money. We typically don't have to use our current health insurance in the typical fashion, unless we have something big or traumatic happen. Typically, I think most people should get plans with HSAs, save, and I think HSAs will probably be bigger and bigger in the future.
So just kind of break down what a HSA is and how it's different
So
from
it's a
insurance.
health savings account. Basically, you take pre-tax dollars, either from you or your employer, that's put pre-tax into an account that you can just use for medical expenses. And that could be doctor's visits, that could be eyeglasses, that could be contacts, that could be dental, that could be vision. It could also be medical supplements. It just has to be healthcare related.
And then when you take it out and you use it for something with healthcare, you're not taxed on those dollars.
No,
correct?
you're not taxed on those dollars at all. So it comes out pre-tax, and then you don't have any additional tax when you purchase with it.
And I may be asking the wrong person. Do you know what the limits are on those usually?
They change year to year. They typically go up year to year, but I want to say right now, per family, it's somewhere around $8,500 a year.
And that's crazy thing is, like, you should add 2 more zeros onto that. Like, that's what's frustrating about that.
Well, if there were 2 more zeros onto that, you wouldn't need health insurance, and it'd just be a cash-based system, and then the innovation would follow.
Weird, right? Weird.
Yeah, weird.
But we'd cut out some pretty big players, and I'm sure some pretty big politicians too.
Absolutely, I think it would probably upset Washington more than any place else.
Yeah. So, kind of tell me about your journey of going from, being in an industry that is traditionally medical management is really what a lot of them is. A lot of it is, or medicine management. Sorry, is what a lot of it is. What was the point where, or what did you see that made you even think, hey, I need to diversify away from just doing med management?
So, primary training is anesthesia. So I did anesthesia, but part of anesthesia is we do nerve blocks for surgery. We run labor and delivery. We run the ICU. I really enjoyed, basically the interventional part of what we did. So the hands-on doing procedures. And so I decided to do a fellowship at Texas Tech in interventional pain medicine. So yes, we did opioid management. We also did blocks, ablations, minor surgery, spinal cord stimulation, kyphoplasties, to basically reduce overall burden of disease of chronic issues. And so, I learned coming out that I knew that part of my specialty was being, very versed on opiates and other medications that treat nerve pain or other anti-inflammatory type of, scenarios. But the mainstay of my training was really focused on using things that aren't addictive, aren't drug related, to really help people recover their function. Pain is funny because, your 3 out of 10 pain may be my 5 out of 10 pain. Everybody's pain scale or visual analog scale is all over the place. But we really focus on functionality. What are your activities of daily living? What can you do now after treatment that you couldn't do before treatment?
What made you make that shift though, man? Like, was it you saw what other people were doing, you saw where it was going, you saw, like, what was it that made that shift in your brain?
Well, just looking at, dealing with patients that take long-term opioid management is really a sad state of affairs. Typically, it's, whether you have a true addiction, everybody becomes dependent to long-term opioid management. So we know there's side effects. We know that there's things that are taken from patients when they do these, and learning the interventional side really shows, like, hey, there are procedures that are very quick, very low risk, that can really improve functional outcomes. And it makes you kind of want to explore those options a little bit more and kind of focus your practice on those, modalities of treatment.
And which a lot of them are outside of insurance.
A lot of them are outside of insurance, and then insurance fluctuates. It's, you're always playing the game, and insurance is constantly changing how many medial branch blocks you need before you can get an ablation. I've been practicing long enough. It used to be 1 set. Now it's 2 sets, and everybody follows Medicare guidelines. And, Medicare will say, yes, we're going to cover this procedure for right now. And then there's not great data on it, and then they take it away and then it comes back. So it's really, it's like hitting a moving target treating patients. And so always falling back, having things like regenerative options for patients, having cash paid procedures for things that, don't fall into a regular, algorithm of treatment is really nice.
Um, can you use CBD to treat chronic pain?
So CBD actually is a very potent anti-inflammatory. So you can use that to treat chronic pain in some instances. So orthopedic type of arthritic type of problems. Typically, it takes a higher dose of CBD, which can be somewhat cost prohibitive. Usually, it takes like 100 milligrams 1 or 2 times a day of like an oral tincture of CBD to be really effective. Is what the data
100
would show.
milligrams.
100 milligrams. Twice,
So you
twice a
think
day.
of like the 10 milligram vials, right?
Yeah. So you're talking about like 100 milligrams twice a day. So you're looking at, for most, if you go get that, it's going to be like $50 or $60 a month just to have that. There are probably better supplements that are probably better than CBD, in my opinion. One of them is curcumin, which is the active ingredient in turmeric, which is really, really good, really potent. And then Botswana serrata, which is also known as Indian frankincense. Yeah, they're both part of the Ayurvedic medicine. They're both cooking spices too. But together, that's what I put patients on when they don't tolerate anti-inflammatories or NSAIDs or their own blood thinners and can't take those. They're really, really cheap, and they're also really potent.
Interesting. Where do you find that stuff?
That stuff is usually available online or in big, retailers. The problem with supplements is they are not regulated or tested by the FDA. And so I usually tell people, if you are going to get supplements that are third-party tested. And there's probably 5 to 10 brands that are third-party tested each batch. One that I use is Pro Encapsulation. They do a good job of testing each batch. Just the one that my family takes because I know it's what it actually that they put on the bottle is actually going into your body, so it's safe and effective.
Interesting. What do you ever use? Do you ever prescribe CBD for your patients?
I have. So certain patients, they've had a great response to the CBD, or they want to try something different, just kind of out of the box. So CBD works really well topically as well. So if you have hand arthritis or knee arthritis or shoulder, any joint that's close to the surface of the skin, a topical CBD works really well for that as well.
What specific? Because there's a ton of CBD companies out there, right? Like everyone has CBD. What are the ones that you trust and go with?
We've carried Higher Peaks, which is basically a topical CBD with other essential oils in it. Has worked out really well. Just the pure tinctures are really good too, and you can get those at most dispensaries. I typically, for a lot of reasons, try to have people shy away from THC involved with the CBD. I think unless you really know what you're doing, that's probably something people should avoid.
That's fair. That's fair. I could see that could be a reaction that they might not be
Exactly.
expecting.
Yes.
It was funny. That would be a tough thing to like gauge on how someone's going to react to it, especially if you're prescribing 100 milligrams of
Exactly.
CBD.
So you want it to be a pure, a pure distillate. You don't want it to have a lot of contaminants or even THC. So you want it to be as pure as possible.
So what got you into really having a practice tailored to treating personal injury patients?
So, I think acute pain was always been very interesting. I think when I was training, saw patients in the hospital or patients in the emergency room. I think when you go to the emergency room, I think there's an overwhelming feeling that you're not well treated these days. Even car accident or acute issues, it's like, hey, you're not dying. Here's your prescription. Go see your primary care. And then, most people, it takes a while to go see your primary care. It may take months to get in, or weeks to get in. And we started, seeing and treating injury patients. Our schedule are pretty open to see acute people with acute problems because, the step between the ER and, God forbid you need a surgery, there's a lot of room in there to treat patients. And we typically, enjoy treating people conservatively. Obviously, I'm an injection specialist, but we start with, anti-inflammatories and neuromodulators and muscle relaxers and physical therapy and chiropractic care. We assess people for traumatic brain injuries, for, the need of, do you need someone to help with PTSD or driving anxiety? And it was just a very kind of diverse, workup for me and my, staff that we enjoy treating these patients because these patients, number one, weren't getting great treatment. Some of them are not insured or underinsured, and it was really just a deficiency on the system to take care of these patients.
Is PTSD after a car accident fairly common?
Very common. So either a true PTSD or driving anxiety. I think anybody that's ever been in a car accident, when you drive back through that intersection, there's a reaction. Okay, that reaction could be small. You could feel bad. Some people have a full-on panic attack. And if it's, most accidents occur within 5 miles of your house, like you're going to go through these areas again. So you need to be able to be mentally, stable to go through that area and, be around, cars and drivers. And it's a big deal. So it's very, very common.
What's the most common injury from a car accident?
So I would say the most common injury is probably going to be cervical whiplash. And cervical whiplash is just classified as what we call an acceleration-deceleration injury. So you go fast and you stop. And that causes strain to the ligaments and tendons, including the disc and the facet joints of the neck.
What are the most effective treatments that you use for cervical whiplash after an auto injury?
So, obviously, muscle relaxers, anti-inflammatories, are kind of a mainstay. Physical therapy, chiropractic care, dry needling, and though we use shockwave therapy as well. So that's another good one. If they do not get, complete relief with conservative care, then we do offer, facet joint injections, medial branches, epidurals, more advanced orthobiologics, so PRP, stem cell into those areas as well.
What is shockwave therapy, and how do you use it for cervical whiplash?
So shockwave therapy is something that I kind of brought into my practice a few years ago. It's basically the same technology that we use to break up kidney stones. So it's a very high-powered ultrasound wave. You kind of can hear, but we put patients basically in a pool in the hospital, and we shoot these shock waves to break up kidney stones in the ureters to break up, so they can pass, without incident. So it's the same kind of technology, except it's just in a handheld device. So it's actually putting a high-powered sound wave that penetrates down into the tissue. The device that I have will go 12 centimeters deep. But what it does is it stimulates, micro irritation. It causes increase in blood flow, nitric oxide release, growth factor recruitment. And so it basically stimulates the tissue to heal.
Interesting. Wow. And you use it on fairly often on car accident victims?
We do. So we use it for a lot of major joints, neck, spine. We kind of avoid kind of hollow visceral organs with it, but because it goes so deep and it's so powerful, but mainly for orthopedic problems.
Have you ever used it on yourself?
I have. Yeah. It's a pretty interesting experience. It feels like you're getting kind of popped with a rubber band to start with, but your body kind of gets used to it. So it becomes much more smoother.
It's really cool to see all these conferences come up. Like Toby is one of the conferences where it's around orthobiologics and regenerative health. But I was just at the Toby conference, and what I was most impressed with was how many surgeons there were there. That I was like, man, this is in a lot of ways, this is more interesting to me than NASS, right? The big spine conference for spine surgeons. I'm like, because one, this is expensive to go to. It's extremely expensive to go to. So the people that are here want to be here. And there weren't that many like recruited speakers, right? There weren't that many industry paid speakers there. It was almost all people just wanting to learn. And the cool thing is that it was all physicians that were wanting to learn. What are some of the conferences you go to for that?
Yes, so Toby's been a good one. I've been to some regenerative medicine, conferences before, some ultrasound courses. Aspen, American Society of Interventional Pain and Neuroscience, has been good as far as teaching. ASIP, which is another one, anesthesia-based for pain. The conferences are very helpful. Obviously, there can be industry-led, but innovation, is alive and well in the medical space. With regenerative medicine, I think you see a lot of surgeons looking at it as, we all know that surgery is a last resort. And if we can do anything preemptively, whether it's covered by insurance or not, to keep a patient from needing surgery or getting surgery, I think there's a win-win for, society. So I see a lot of surgeons that are performing, less invasive procedures. Obviously, if you need something super invasive, it needs to be done. But I would say, less is more when it comes to surgery.
It is crazy to me, and I'm always I'm always interested in how physicians that offer cash paid remedies, right? When they have a patient come in, and let's say the patient is like, you told me as a doctor that I need to have PRP or stem cell, or that it could help, right? But it's not covered by my insurance, and they balk at a cash price. But at the same time, they drive a new car that's financed, mind you. It is beyond my comprehension why someone would invest in a car, a streaming subscription, you name it. But they balk at the idea of, spending $3,500 to possibly stay off of the operating room table. Do you run into that fairly often?
I mean, yeah, I think people have an understanding kind of beyond that. They don't understand where their health insurance comes from. Most employers pay all or a higher percentage of it. I think if patients were writing a check every month for, $800 to $1,500, they would realize that, hey, your health insurance is expensive, and we feel frustrated when it doesn't cover things that are, the best option moving forward. So I definitely, feel sorry for the patients to realize that they've paid a lot of money out and they may not fully understand what it does and doesn't do. But I think more and more, even, my family, as I spoke earlier, we don't really use our health insurance. We use our HSA. And so having an HSA to utilize for cash-based procedures is super critical. As far as, telling patients how and why, health insurance is a business, and their business is to not pay. Just like, car insurance is a business, and their business is to not pay claims. But that doesn't mean that you don't need it.
Absolutely. Have you ever been in a car accident?
I have been in a car accident.
What did you do after your car accident?
So I was younger, so I haven't been in a car accident in any time in the near future. But I think the biggest thing is to go get checked out. See a provider, whether it be your primary care physician, whether it be an accident specialist like myself, or whether it be a chiropractor. Have somebody go over things with you. Injuries in a car accident, they aren't always immediate. Sometimes pain flares and begins days later or weeks later. Sometimes you don't understand your functional deficit until you go get on your mountain bike and can't do it because you have pain. So everything's not always immediate. So I tell people, yes, people should, even if you're healthy, establish with a provider of some sort who can help you make medical decisions, when things arise.
What are what are the biggest 3 mistakes that people make after a car accident?
So the biggest mistake is not going to seek care. So delaying too long. They don't document properly damage or functionality, and then just making sure you get the other person that was involved in the accident, their insurance, their ID, just so you know kind of what's going on. So just documentation and then seeking care are the 2 big issues.
And then making sure the person that hit you or the other person in the accident.
Well, that leads me to another subject is, in Colorado right now, I want to say either a fifth or a sixth of Colorado drivers don't have car insurance, which is huge. So that means if someone that is uninsured hits you, there's no way for you to get reimbursed or compensated unless you carry uninsured motorist coverage. And so that's a policy of your own that basically protects you when you get hit by somebody that is underinsured, so it doesn't have enough coverage to cover your health care, or they don't have coverage at all.
In providing care for people that are in car accidents, has that changed your perspective and maybe some of the products you buy from your insurance company?
It has. So, definitely look at, the amount of coverage. Do you have uninsured or not insured motorist coverage? We increase those, kind of benefits. Also, definitely look at what safe cars are out there. It's Colorado. We have a lot of accidents. It's some of the worst in the country, and our rates are really, really high. So it's really important that, you make sure that you're covered and your family's safe.
Yeah. What are the minimums in Colorado?
So the minimums are $25,000 in coverage, and that's kind of per, event. So it's really low. Obviously, if you're super hurt, $25,000 is not going to pay for your medical bills. So I tell people, if you're driving in cars or riding in cars, obviously you need to make sure that your current policy has a pretty significant amount of uninsured or underinsured motorist coverage.
That's crazy. 20% of Colorado drivers are uninsured.
Correct.
That is wild. Why is that, do you think?
Well, some of that has to do with just cost of insurance. Some of that has to do with the state not enforcing tag laws, which they kind of fell off during COVID. Has to do with migrant population that aren't here legally, and so they can't get regular coverage. So has to do with basically just Colorado not doing a great job of enforcing its laws.
Do you see a lot of patients that were hit by uninsured motorists?
See a ton of patients hit by uninsured motorists.
So they're on the bill for that for most of the time.
So they are. So their uninsured motorist coverage is what is helping take care of them in the meantime.
How much? I have no idea. How much extra is uninsured motorist coverage?
It depends on obviously the vehicle and how much you want, but I mean you're talking small amounts like $10 or $25 a month.
Oh wow! And did you have uninsured motorist coverage before you started treating personal injury victims?
I had some, but not enough. Let's just say that.
That's fair. What excites you? Like, what are you interested in? What are you hopeful for in the future? What modalities are you really excited about in treating pain patients?
I think moving more and more away from traditional steroid type of injections into regenerative options. So coupling shockwave with PRP with bone marrow aspirated stem cell. There's emerging data on some of the amnio products, not necessarily stem cells, that could be interesting. Exosomes, which are vesicles carrying messenger RNA to stimulate growth and healing in the body. I think there's going to be a move away from less and less surgical consideration and more orthobiological consideration first.
So a lot of these therapies that you're talking about up until now, it's kind of have been only reserved for the elite, the athletes, or the $1 million horses, right?
Yep.
What changed? Why is it so much more accessible now?
Part of it is just there's data out there to say that this is effective. Each of these require kits, and the kit cost has come down. Having centrifuge in the offices have come down. I think you got to follow the money and follow the industry. There's a big demand in cosmetics for PRP and stem cell. I think that's driven some of the acknowledgement of it. There are stem cell clinics that aren't allowed in the U.S., kind of in Mexico, and I think some celebrities have been online and kind of introduced mainstream media to some of the cell expanded stem cell clinics in Mexico and in the Caribbean, and so there's just basically awareness has been raised via social media to orthobiologics.
Why are some stem cell, or what are the stem cell clinics outside of the U.S. doing that ban them from being in the U.S.?
So basically, they are taking the same bone marrow harvested stem cells and they're tissue expanding them. So they're putting them in a lab and they're growing more and more of those stem cells. The problem is the FDA in the U.S. basically states when you take a product outside of the human body for more than 24 hours and manipulate it, then it becomes a drug and it needs to be regulated by the FDA.
So what stops that process? What is tough about that process?
So the tough about that process is if you're going to tissue expand, 1 million stem cells into 50 million stem cells, that takes time in a lab to grow. And so that has to be outside the body for an extended period of time. And so each drug, if it goes beyond 24 hours, you've got to get FDA clearance to go through, just like you're getting a drug, through the federal regulation, which takes about 10 years.
And how much money?
Yeah, and 10 years and $20 million. So for each individual, it's just not feasible. And so a lot of your clinics are doing tissue expanded stem cells. Some are also doing amnio derived from other placebo sources and core blood sources. And there's, some people would say most of those are donated sources, but for some of them that aren't particularly, there may be some ethical indications to those.
Interesting. So, I guess what are some of is there a specific patient that you have in mind that you can think about that you're like, man, this patient is the right patient for PRP or stem cell therapy?
I think every patient can be the right patient. I think the patients that do the very best are people that, number one, young and healthy, so less than 40 years of age, who have been involved in an acute event, car accident, slip and fall, traumatic event that has significant either facet issues or disc issues, that have been otherwise healthy, kind of single site or single level issues that they respond probably the best to the regenerative options. Whether it be, I also tell people one key factor with injections in general, especially regenerative injections, is everything should be image guided, whether it be X-ray guided, ultrasound guided, just to ensure that it goes in the right spot with safety and efficiency.
It's funny too, because since it is unregulated, I have personally known people that have gone to, I'm not even sure what type of clinician it was, but they would get it injected into soft tissue for like spine related issues. Um, some people were having it injected into the fascia, like just some stuff that I was like, what should you look for if you're a patient that is seeking out good stem cell therapy?
I mean, I want to go to a board certified credentialed provider. So I want to go to a MD or DO that is in their specialty. So whether it be an orthopedic, it'd be interventional pain, whether it be, a neurosurgeon that understands the anatomy and also uses image guidance. So it needs to be done under either fluoro, which is live X-ray. It needs to be done or under ultrasound guidance. This could be done in a surgical center or in the office, depending on their setup. But it needs to be, number one, and ask about what kit they use. For PRP, the data would suggest that you need to be greater than 7 times physiological concentration of the blood to get a truly effective concentration. So it's more than just, this is just some provider somewhere with a needle and a syringe that's going to give me a regenerative option. So yeah, I tell people to be critical about it.
Are there any dangers of medical tourism?
I think medical tourism, I think there's, cash is king, like we said earlier. You need to be careful. Sterility is a big issue that I have with, whether it be certain surgical procedures, stem cells, sterility within the processing of the PRP or stem cell, sterility of the injection, and then just, most physicians, a lot of these procedures are done very easily and very safe. What you really understand as a physician is you get paid for when something doesn't go right, not when it does go right. And so dealing with complications is dangerous because if you're medical, tourism, you're on a plane back and forth, and the complications get way riskier when you're flying, someplace far or short after procedures. The risk of DVTs, the risk of infection, the risk of just, overutilizing an area where you probably should have been home resting and relaxing.
Do you think that what's offered in the U.S. is comparable to what's offered outside the U.S.?
Yeah, I think in the orthobiologic space, besides the tissue expanded stem cell, I think most of what we offer here is comparable. I do think that certain places that offer the tissue expanded definitely have a leg up as far as the technology, but I would be really critical and really picky of where people go offshore.
Really, like specifically, where would you never go? Where would you go?
So some of the Asian places you need to be really careful with. Some of the South American places, really careful with. I would say you want, board certified physicians, maybe have been trained in the U.S. You want, definitely I would ask for, what are some very well-known referral sources or, patients from the U.S. that have been there, that have had good outcomes. Also, potentially ask someone go see someone that currently does regenerative medicine here. And if you want to do tissue expanded, ask them where you should go. One of the ones that I refer people out to is Regenix down in the Caymans.
Really?
Yeah.
Huh. Yeah, it's interesting how much innovation actually comes out of the islands, right? Because there are so many spine technologies that they actually collected a lot of their data as cash pay in the Cayman Islands, and then eventually went through the FDA process and got a 510K or a full IDE study and full approval, FDA approval here in the U.S. And some of them are great technologies.
Yeah.
What are what's different about your practice when treating you called yourself an accident specialist. What is the difference between you as an accident specialist and just the normal ER doc?
It's a great question. So obviously, ER is going to be basically making sure that you're not going to be close to death anytime in the very near future. As an accident specialist, that we're beyond emergency care. We're looking at these short-term and long-term implications of being in a car accident. So not only am I making sure that you're not going to die here in the next little bit, but what trauma indications are, and that includes proper documentation because usually there could be adjusters involved, insurances involved, attorneys involved. So proper documentation of your injuries is critical. Also proper workup. When do you get an MRI? When do you get X-rays? When do you start physical therapy? Just having that knowledge base to know the algorithm of treatment, doing this, for a decade is super important.
So really, it's the experience that they're really getting. It's not
Yeah.
even it's not a a wide, hey, are you alive or not? It's, hey, you suffered this event that I've treated thousands of,
Yeah.
as opposed to the ER doc that sees.
Yeah. And then just the next step beyond the ER is just, yes, you're healthy, you're alive. And then what do you do next? And then a lot of primary care doctors, yes, they've seen patients with car accidents, but they don't treat it very often. They don't treat them very well. And so just, someone that does it all day, every day, is going to give you a different level of service, which is going to, number one, save you time and money in the long run.
Uh, Absolutely, and it's interesting. What are the biggest apprehensions that people have in going to get checked out right after a car accident?
Who's going to pay for this? Is probably the biggest one. Obviously, if people don't have insurance or underinsured or don't have the funds to pay for their own copays, is a big issue. And so the good thing is there are ways of physicians being paid and reimbursed that don't go through traditional health insurance mechanisms.
What does that look like?
So there are some, companies out there that will actually pay for your care up front until your case settles. So that's a traditional one. There's MedPay, so part of your own insurance will pay, an X amount in healthcare bills, for your care, and that's just part of your regular premium.
Wow, yeah, and I could totally see that of someone their car just got destroyed, that which is their transportation to work. So not only do they have anxiety around how do I get to work, what am I going to do to replace this car that I may not be able to afford, but now I'm going to stack a medical bill on top of it. What is your advice to people when they get in a car accident?
Yeah, I mean, their advice to people is, typically, make sure you document everything, document your losses, document your time away. Definitely, communicate with medical providers as quickly as possible. Get checked out. Some people, I do think, hiring an attorney is probably going to be the best thing for them long term, to ensure that their rights are protected. They do a great job of that. Some people choose not to use an attorney, and I understand, but there's an apprehension of, oh, I got hit by, a young driver, and, that's understandable. But the reason you have insurance is to make sure that if something does happen, you're liable and you take care of the people that you've injured. So I definitely tell people, it's usually is best to seek, counsel from an attorney.
Tell me about a little bit about the workers' comp game. Like that is 100% like a growing facet of society, in that so many employers are getting workers' comp insurance.
Yeah.
Because there's obviously a ton of liability. Tell me about some of the workers' comp injuries. What's the most common workers' comp injury you see?
Workers' comp injuries, they could be anything, but usually it has to do with lifting heavy. Obviously there are traumatic things. Also, another work comp is people that are working on the job and involved in a car accident. That's also workman's comp as well. So, and that's where some of my expertise comes into it. But, lifting heavy, back injuries are super common. Also just overuse injuries, whether it be a baggage handler, for one of the airline companies that are constantly throwing bags. That's where we usually see a lot of kind of long-term mainstay, regular injured people.
And then what does that process look like compared to the personal injury process?
So typically, work comp's a little different. You usually after your injury, go to an urgent care where you get checked out. The urgent cares are typically in network with work comp. It's the work comp patients. Then they'll refer you out to kind of a case manager physician that is certified to work that industry. So they'll monitor you, and they'll also send you off, kind of like a quarterback, to a surgeon if you need to, or conservative care if you need to.
And how do they find which surgeon or which provider they refer to?
So that's usually, just in network. So people that they've had relationships with, it could be, you can still choose who you decide to go to. They typically want to stay in network because it's cheaper for them because they have already contracted rates, but there usually is some variability for out of network providers if you have somebody that you trust and know.
Um, what is an example of a workers comp patient that you've helped?
So a work comp patient that I've helped is actually talk about a baggage handler. So I've handled several people that work for airline companies that have been injured on the job, had some back sprain and strain, and some cervical sprain and strain. And so, sometimes doing that day in, day out, something happens, something's heavy, adverse weather, adverse event with equipment that may cause, a cervical spine injury or a lumbar spine injury that results in a disc herniation.
When you treat a disc herniation, again, coming from being a spine rep, I'm like, oh, dude, fusion, let's do it.
Yeah.
What do you see to best treat disc herniation?
So disc herniation, they can be problematic. Usually once a disc is herniated, it doesn't go back. Sometimes the body will scar over and heal over it a little bit, but once you have say a 5 millimeter herniation, you have a 5 millimeter herniation. We start with conservative care. We see if the body's going to, respond in favor to reduce the side effects from that. Herniations can cause, regular neck pain. It can cause some nerve irritation, which causes sciatica or burning and tingling down the arms or legs. We can do injection therapy, so steroid injections, PRP, stem cell into the, in and around the disc, sometimes into the disc or sometimes in the epidural space, can be effective. But ultimately, if those things, don't respond to care, they get surgical either fusion or a microdiscectomy, which is basically going in and shaving away or, pulling out some of the herniated disc area.
And what happens after, let's say that someone has a herniated disc? What is your immediate advice to them? Who do they see first? What if they are prescribed surgery? What would happen to you if you had a herniated disc?
Well, just a evaluation. So a physical exam, how much neurological involvement, how much sensation deficit, how much weakness is involved. We do, a neurological exam where we test reflexes and other, indicators to see how much nerve compression is being done. If it's limited and not super extensive, we will evaluate with an MRI to see, number one, how big is it? Any other comorbidities like congenitally short pedicles causing some stenosis in the area, and then we treat it conservatively at first, and we slowly work into more aggressive treatment options, whether it be decompression therapy performed by your chiro or epidural steroid injections or PRP or intradiscal stem cell.
Do you refer to chiropractors?
I do.
Do you think chiropractic helps?
They definitely help with acute injuries. I think my algorithm is chiropractic care is really beneficial early on after an acute event. A lot of people are in too much pain or too much discomfort to be able to participate with physical therapy. So I think chiro, continued normal, healthy motion is super important early on after a traumatic event. Also, they have some other modalities of treatment, whether it be dry needling or decompression therapy, that really can help with discogenic pain as well.
Yeah, it's really interesting to see that like some of my healthiest friends do all these things that are typically either not covered by insurance or are take some type of investment on their part into their own health. And do you hope to see insurance start covering more and more of these modalities like PRP, stem cell, some of these regenerative things?
I definitely I hope that there's more access. Insurance coverage is a double-edged sword. Sometimes when things are covered, they lose their value to the physician and to the patient. So it's more about coverage as long as we have more access to the masses. You know, some things get, you know, cheaper when they get covered. Some people things get more expensive when they get covered, and unfortunately, physicians, we don't have a lot of control over that.
It is absolutely wild to me to see, and I've told multiple surgeons this. I'm like, it is crazy to me that you guys sell a product that you don't get to set the price on. You know, like you don't get to set the price on it, really.
Yeah.
Now, if you go outside and you do the cash pay side, sure.
Yeah.
But largely, the perspective of price for healthcare is not determined by you.
Yeah, so I mean, Medicare tries to cut reimbursement every year, and we do typically get cut a little bit every year. So we're actually getting paid less and less every year by Medicare, not more and more, even with inflation being pretty incredible over the past few years. So physicians and providers and hospitals are getting paid less and less, not more and more.
Do you think the answer is outpatient surgery?
I mean, definitely, I see tremendous amount of abuse with the hospital systems, with tons of administrators, tons of non-provided cost, or so not provider cost, that is really not needed. You know, I think most everything can be performed in an ambulatory surgical center. There are a few things that do require a hospital setting, but I think we'll continue to see a shift more and more to ambulatory issues.
So here's a question I always ask because I'm genuinely really interested in this. SI joint fusion, we see it in with surgeons and with spine surgeons somewhat, but I see it being way more widely adopted by interventional pain physicians. Where do you see SI joint fusion being most appropriately allocated as a modality or an offering for a procedure in surgery, like a spine surgeon, or an interventional pain?
Well, I think there's really two schools of thought. Interventional pain is seeing a lot more of those patients. They're going to see a lot more of those patients early on that may not need surgery. I think a lot of the surgical consideration are patients that, you know, have failed traditional workups, traditional modalities that the surgeons get a hold of that, you know, are being offered a surgical correction. I think there's a lot of new emerging technologies in the SI joint field that I think will be very beneficial, that are used by surgeons and by interventional pain specialists. Really, unfortunately, there's a lot of new stuff out there that doesn't have a lot of data-driven, you know, outcomes to it that I think hopefully will, you know, be very soon vetted to be, you know, a good data-supported treatment option. But, you know, right now I think there's a lot of new stuff without a lot of data.
I mean, that's kind of, at what point is there enough data to be like, oh, this new stuff is no longer new stuff, but is good stuff based on the data?
I mean, you look at traditional mechanisms, the FDA, and getting, you know, are there a predecessor that has good data? I think with the SI space, SI bone, their, you know, torque screw and their triangle is what all the data that we're using to basically make sure that some of these other products they have some, you know, usability. But then, I mean, there is no study comparing any of these products to any of the, you know, Insight study or some of the SI bone original studies.
Yeah, it's interesting to see because like the original, some of the original products are widely not used, and where the predicate product is not really used that often, but the 510K that use that predicate product to get the 510K is used a ton.
I think the 510K is a great tool to get innovation done, but I think it is abused, to be honest with you.
Absolutely. It's interesting to see what, again, the predicate product was and the final product is, you know?
Yeah, they can vary wildly. I mean, it's sometimes there has no similarities whatsoever.
As a clinician, how do you determine, you know, someone brings you a new product? How do you determine, you know, this is viable, this is not?
I mean, it's really difficult. You know, if I would open my doors, there'd be new products in every week, so there's definitely innovation happening. It's, you know, I think you have to look at durability. I think you have to look at cost. I think you have to look at, you know, your own personal practice. Not everything is suitable for my practice. You know, what are the risks? What are the benefits? What are the costs to the patient? What's the cost to my office? First rule of medicine is do no harm. And I think, you know, we really need to make sure that what we're offering, number one, is not just a quick and easy fix, especially with the SI joint space. a lot of those products aren't removable and have no ability to remove. I think, it's how do you take it out is a big issue, and who deals with your complications. And that's been a big criticism of interventional spine physicians is, a lot of us can't deal with our own complications. So, I think that needs to be looked at a little bit more regularly.
And I guess that's the question is like, what, with an SI joint fusion, how would a interventional spine physician deal with the complications?
So that's great, whether it be infection or improper placement, and that's where, can you remove this device comes in. I think there needs to be some sort of, avenue to remove, or at least a physician backup, maybe a surgeon of some sort that, will back you up for your cases just to make sure there's an avenue when something adverse does happen, that there is availability to make sure that patient's, the continuation of treatment's there.
In this is kind of more of an industry question. What factors more, or how much does it weigh? Let me put it this way. How much does the rep weigh into the decision making of if you're going to use a product or not?
I think most products are great. To be in the industry for any period of time, there's usually a great product. I think what makes a great product great is the support from the rep. I think reps can really, their experience, they've seen thousands of these cases, and even a physician may have just done 10, 20, 30, or 100. But most reps repping these cases have way more experience seeing, looking, and using these tools. So I think reps, number one, are essential to medical device and essential to, I think what we do every day. I think where, there's some issues for growth is, number one, are these reps carrying the best product out there? What's the reimbursement, to the rep or to the facility? Cost is always an issue. And then innovation is always more expensive. And how do you quantify when to use the newer product versus the traditional one?
It's funny. I'm coming from a W-2 position and then going into distribution. That was like the biggest driver for me in leaving a W-2 position is you could only sell what your company had. And so the idea of something being more innovative that was made by another company, you couldn't talk about that.
Yeah.
And it drove me up the wall to where it was like, once I was a distributor, it was a no-brainer. I'm going to go after everything that's most innovative. Obviously, you're constrained by contracts at hospitals and stuff like that. But if you have a strong enough physician relationship, usually they can push and like, this is really worthwhile to push for, or let's take it to the outpatient surgery center. And that seemed to be the real decision making for the hospital is like, wait, we're going to lose these cases. But yeah, I'm always interested to hear kind of what that looks like, because inevitably the hospitals will usually always try to drive some type of separation between the physician and the rep. And even the rep's own company will try to make that division to a degree. But it's a multi-billion-dollar industry of trying to get you guys to change something you're doing.
Yeah, and it's not going away. I think, at the end of the day, whether it be physician, facility, rep, if you have a patient-first model, and that is your ethos, and that is one condition that you will never waver on, I think you will stay in business for forever. And then whenever you are not patient first, if you're money first, I think you have a very, very short runway.
Can you usually tell when you sit down with like a new rep or someone from a company, kind of what their real motivation is initially?
Absolutely. It's number one. I mean, there's innovation, but we all kind of know the players in the space. We kind of hear, through continuing education, through going to a new conference, we know kind of what's up and coming. So we're usually not blindsided by just true innovation that walks in the door. You usually have some sort of idea of it, but you can really, based upon, what are you being sold? Are you being sold a solution to an issue? Are you being sold a revenue generator? Are you being sold, or just something different? You can usually kind of tease out kind of the play very quickly.
It's so funny. Like, again, being a distributor for more years than I was W-2 even now at this point. Anytime I sit down with a mid-level manager from a company who are W-2 with those companies, even though we contract them, right? there are some that drive me up the wall when they use terms like, oh, this is disruptive. This is like, there are these like, there's always like the term of the generation or the term of that period or era in spine or any kind of medical device is, oh, this is disruptive, or, you know, this is emerging tech. It's, I agree with you, man. I couldn't sell something that I didn't believe in.
Yeah.
And it would be really hard. I feel bad for the people that have to, you know, if they're feeding their family, of course, that's the most important thing for them. But yeah, I'm excited to see what comes out. I'm actually really excited to see how interventional pain interacts with the SI space. Because if it's responsibly done, I think it could be a good thing.
I think it will be. I think, number one, I think there's some limitations on interventional pain. There's some skills that are lessons there, you know, as far as surgical, you know, procedures, you know, fixation versus fusion. You know, I think there's some educational deficits that our training our space has become way more interventional. I think our training has not caught up with the innovations that are taking place. I have big hopes and dreams for the interventional spine space. I think there's going to be a melding of surgical procedures and interventional procedures from both orthopedic spine and neurosurgeon and anesthesia, physiatry-based practices. I don't think it's going to be to the point where we're going to see interventional spine take away what the interventional cardiologists did to the cardiothoracic surgeons. But I think there's going to be way more percutaneous done surgical interventions in the SI joint and in the spine in the next 5 years that is going to blow our minds.
Yeah, absolutely. And I know that you'll be one of the guys. You're one of the ones that'll take a hard look at it and help drive that forward. It seems like. Well, man, thanks for coming on. Dude, thanks for bringing a Abita. This is nostalgic for me having an Abita. Again, it's weird having an Abita and not having a crystal hot sauce next to
We'll
it.
have to remedy that in a minute.
But yeah, thanks for coming on, man. And yeah, this is Back and Brew.